Welcome back to Let's Talk Value podcast series. Today with Professor Dr. Jörg Goldhahn from ETH. Welcome, Jörg.
Welcome.
My name is Verena Voelter. I'm the host of this podcast, as the listener and the viewers, maybe some do watch our video recordings as well, know. And today, it's really my pleasure to talk about particularly what Jörg's involvement at ETH and Zurich, kind of the next generation of providers and medical people, let's say in general, but also research, obviously. And so we'll talk a little bit about the translational transfer of knowledge as well, and all in the context of collaboration and how we can manage those intersections across the 5 Ps, but whatever intersection in the healthcare value chain. And Jörg, as you may remember, my first question is always pretty 50,000 helicopter view level. What does value mean to you when it comes to healthcare? And you're a doctor yourself, so maybe even from a doctor-patient perspective or from your current role, whatever comes to your mind that you want to share with the audience.
You start with the most difficult question, which is good. That's really my personal perspective. I would value very much, time and good health. So I really like this term health span instead of lifespan. So the time that we have in the best possible health. And in this context, of course, also preventative measures so that we don't become sick, which is unfortunately not highly rated in our current systems. So I would, if I would have a wish for free, I would really try to spend money more for prevention than for treatment to really keep us in a good health status. So that would be for me a really good value for money or for, the measures you take.
That's excellent. And by the way, it's called healthcare and not sick care, right?
Yeah, but we do sick care, and we call it healthcare.
Do you have, it's an excellent part of the whole value-based healthcare chain, like deliver outcomes. And for this, we need to actually do more on the prevention side and keep people in healthy living. Do you have any thoughts on, and we don't want to spend too much on what the problems are. We want to be more forward-looking and what can be done differently. But maybe one thought on why that is? Why is it so difficult to?
At the moment, it's a problem of incentives or reimbursement, so that we only get reimbursed when we have tooth pain, and then we get more or less reimbursed when we take action there. But we should, let's say, keep our organism more healthy to prevent the sequelae of sick status. And nowadays, we have much better options for early warning, for sentinel functions. Let's say in physical activity, when we see that patterns start to change, we could start earlier with preventative measures instead of treating the consequences. We know that we can detect, for instance, Alzheimer's at very early stages with changes in gait cycle, or we specifically have a project at the ETH where we look into consequences of obesity. When does obesity become pathological? So when do we have consequences of this status? And of course, then we could rather work on the obesity itself before we see those consequences. And it's the same with physical activity, with neurological things. We have the measures nowadays with all the new wearables and chatbots, all the new technology. We can detect early signs of disease, or even in a very, let's say, early status where we have many more options compared to a late stage, and this is why I think we should invest more into prevention instead of disease treatment.
Excellent. And thanks for mentioning the word incentives, because I think that is the key trick. So while you and I and our colleagues can't quite change the incentive today, we do that work on the side more from a systems perspective. But while we're still within our system that we have, and we want to explore some of the ways that people can still change maybe some of the behaviors now, and you're mentioning some of it, it's like, well, just focus your research maybe on the early part as you do at ETH. So I'm curious to know, because obviously that is one of your key focus areas with your students and your researchers at ETH, some of the projects you already described. I'm interested to learn more about the collaboration piece that that I'm very interested in. It's like, how do different people work together, like in the clinic, the doctor, the patient, your researchers, your PhD students, maybe people that are more engineers. What's your secret sauce? Because it seems to work very well in your teams and groups. So why is it working so well? What can you tell others to maybe replicate in terms of behaviors and things?
I'm not sure what is working so well, or at least there's definitely some potential for
It
improvement.
looks great.
It's another story. Yeah, I mean, the ETH is a technology-driven university, and comparable maybe with MIT or others, with a very strong focus on technology. On the other side, we know that the challenges that we see in society come from completely different ends, like aging, health problems. So if you want to change something there, we need clinical partners, we need people involved in healthcare. And so what we tried to do, started a couple of years ago, to look for clinical partners who want to, look together with us into those problems. And it seems that this is often a good match with certain clinics, because they are often lacking technology or lacking, let's say, the expertise in programming, in machine learning, all those things that are mentioned today. But they have the problems, they have the patients, they have access to patients. So what we try to do is we take the best of two different worlds. Whereas IT typically is a real and huge burden in clinics, and they don't have the time and the energy to look into whatever fancy projects. This is something where I have colleagues who say, hey, as more data as better. So we try to bring together two different worlds and to work together on those common problems. And this is what we now try to institutionalize, where we have built up a network of clinical partners, and then really it's a kind of a try and error principle. With which of the partners can we establish a good relation, and where it's more problematic? Some of the clinical partners are extremely busy with keeping the daily business up and running, and they don't have time for additional research. But others are more open, have better, boundary conditions, and these are then the partners we can really work with, and to really make it a bit more tangible. We started to negotiate with one clinic at the beginning of the medical curriculum that we have established, and now we are in a status where we own 2 floors in a partner house directly above the physiotherapy. I'm the member of the IT committee of the clinic, so we can directly solve problems as they come up and see how we can best perform research together. So we every week we discuss new projects where we try to bring together those different worlds. That's a very kind of grassroots approach, where we start from scratch and build this up, in contrast to some of the, let's say, more helicopter projects where you put a lot of money into and try to bring it down to earth. Yeah? So we do the other way around. We start from scratch with a project and try to build it up and to institutionalize it at a later stage. Maybe this is one of the secrets why stuff works. But could be more, could be faster, could be more effective.
No,
So there's
no, of
always
course,
room.
but I think, yeah, and thanks for making it so tangible and sharing a real kind of example so people can more visualize it in their heads. But you say grassroots, and I think in our experience it's always combined both. So yes, it's grassroots, but you also provide, like, quote unquote, a top down. So there's senior willingness to collaborate.
Absolutely,
And I
yeah.
think so it's like the
agreed
both the sandwich, like top down and bottom up.
Yeah,
but it
you
can't
need
be
both.
only top down.
Yeah, you need really highly motivated clinicians who want to really answer clinical questions on one side, but you also need to have a very supportive management system who
Right.
allows clinicians to do this and to provide the boundary conditions for doing this. And the same on the ETH side. So you need to attract researchers to invest into those problems, and then also to have the boundary conditions to make it working. And we also established a number of models to foster this. So we give you an example. We established a program, it's called MedLab, where a young resident can come with a clinical problem and can work on a problem hosted by an ETH group who has the technology and the expertise to solve the problem, and the resident can spend up to 1 year in a ETH lab to really solve and answer the question. And this is financed by a foundation, so they are really free. They have free time to work on this, but they come with the problem and they take care to implement it at a later stage in the clinic. I know that some other institutions have similar programs, and this seems to work quite well because you have to free up clinicians. You have to provide the tools, embed them in another environment to make them productive, and that's what we try to do. We just have a new round coming up in the next couple of days, and this is really a success program, I have to say.
Yeah, so it's really fostering that joint problem solving
Absolutely.
and sharing the expertise, which is great. And something I also want to say, almost like hashtag relationship, because you kind of implicitly say this is a lot of people just getting together with people, both on the senior level, but also, on the project level.
Something which is for a technical university quite common. I mean, if you want to bring a rocket to the Mars, you need a team. You never do this by yourself. So for the engineers, for the researchers, it's quite common that they work in a team. It's more the medical side where I have this hierarchical approach that people think, only I can save the patient by myself. But we see also this changing in the clinic. But on the university side, it's quite normal. So there we don't have problems. It's kind of really, you have to meet on an eye-to-eye level. You have to have an interdisciplinary team in place and really to start working and put all the hierarchy aside.
And thanks for fostering that on the side. It's almost like a culture shift and mindset and kind of break up old ways of working, particularly in the medical world that you and I have grown up with, very hierarchical and Gott in Weiß in German, we say. So I think this is another nice quote unquote side effect, but I think it's not only a side effect. I think it is essential to then get to solutions really and solve those problems together, is the ways of working and the mindset and the culture. Well, that's amazing. You did in the beginning already mention IT. You spoke about wearables when you spoke about prevention and all the tools we have in our toolbox right now, to even, you mentioned like Alzheimer, like watching gait, for example, and many of us have a smart watch somehow and track things like that. So can you speak a little bit more about that part, how digital health and AI, you mentioned machine learning as well, how can that be an enabler to all of what you said before, like the human connection on problem solving together, but then how does, AI, machine learning, digital help?
So first of all, with wearable technology, and we can create more and let's say better data, which in my opinion are often closer to ground truth. So it makes a difference whether I ask somebody for his weight or I put somebody on a scale, and also which one to trust. So, and the same is true for physical activity, for other aspects of well-being. So we have new tools for quantification. At the same time, we create more data. So we also have to handle the data. And this is something we often neglect. I mean, you mentioned smartwatch. There, first of all, the accuracy is not so much of an issue. But if you want to take those values as base for decision making, then you have to be highly accurate. So that's another the difference between a consumer health device and a medical device. So there's quite some work to do to select the appropriate tools and measures and to embed them into decision making. So we have simple projects like how can we get back anything we measured on a wearable back into a clinical information system so that the value is also available for a doctor to make a decision. It's not enough that it stays on the patient's smartwatch. We need to get it into the clinical information system, and that's something very technical we work on right now to make this happen. Or how can we take advantage of stuff that we all measure anyway, like your fitness level on a smartwatch. Almost many people have those smartwatches, but we don't do anything in a medical sense with those data because it's just a wall. It's not a medical data. It's kind of fun data, and we don't exploit those data. But we would see trends at a very early stage already if you would just simply see, okay, person over a long time decreased activity. So then the question is, what's the reason for this? And this could be a starting point for a discussion with a GP. And then you could explore further, okay, is it the knee or is it the obesity or it's fatigue, So we could use those data even in a clinical context. But at the moment, there's a missing link. We can't use them. I'm not aware of any general practice where I can hand in my smartwatch.
Yeah.
So that's
I mean,
unexploited potential.
No, it's excellent, and it's like the need to structure and inquire and really select with which measures, and then bridge the intersection to clinical.
Yeah, and then of course we can also use it for monitoring. You know, when patients leave the clinic after an intervention, you could easily track their rehabilitation and see how do they get back to normal, or do we see outliers? You know, then we know that the first weeks after surgery are pretty decisive. You know, whether or not they will come back to their normal level of activity, and we could at an early stage identify whether something goes wrong in a rehabilitation process and call them just if we would have the value available. Yeah. So at the moment we need to see them back in a follow-up visit, but if we would know how they are doing without seeing them, you know, you would have much more intensive data. And here then also all let's say the signal processing comes in, because you need to have the right signals, the right measures, and you have to handle the big amount of data. And this is where we then come in with machine learning or AI support, because what we are looking for are patterns, and you know, machine learning is extremely well positioned for pattern detection.
Yeah. What I wanted to suggest in terms of what we already do with the wearables we wear every day for our lifestyle choices, like a smartwatch, is the use of prompts and patient-reported outcome measures. That is basically just an app that can be utilized through a watch like this, or the phone app, whatever, where we then do exactly that. We watch that intersection, that transition, for example, from the hospital to rehab, and what's changing in the gait, in the heartbeat, in whatever the weight, whatever it is we want to measure. So there are ways to analyze this in a structured way and integrate it into the clinical care pathway and clinical decision making to enable the joint problem solving between the provider and the patient in this case. So I think that the whole package of prompts and 5 prompts is something that is designed to help answer some of those.
But there are some nice examples coming up of nicely designed chatbots which assist in this process. And I hope that we see more the next time. Exactly as you say, they can facilitate this interaction process between patients and their treating medical doctors. But again, simply work required to program them, to really make them also very user-friendly, with low burden for patients. There's still a way to go. But that's one of the reasons I like working in my environment, because I have a lot of people who have really crazy ideas, and they come up with novel solutions, and that's fun to test this and to work with those really highly creative people.
Well, this is a very nice, almost leading to the conclusion of our session today. Anything you wanted to make sure to deliver today? Otherwise, we have already topics for maybe a next one in a year's time, and see how chatbot and everything has evolved by then. But anything for today you wanted to leave the audience with?
As you know, I'm highly engaged in education, and I think for me one of the most important things is we have to encourage people to follow their own crazy ideas. We have to enable them, and not just to tell them what is not working. And that's something what need to change, especially in a medical environment where we typically do it the other way around, so that we encourage people to really question things, analyze things, and come up with new ideas. We all know that we have to fix the system, or healthcare systems are much too expensive on both sides of the Atlantic. So we need new solutions, and we need to encourage young people to really question things, analyze things, and come up with novel solutions, and not just turn it down from the beginning. So we need to also answer this, and that would be a main message, that a younger, new generation, we should empower them to question the stuff.
Thank you very much, Jörg Goldhahn.
Thank you. It was a pleasure.